Welcome to the Mountain West AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, thanks to everyone who's joining us from around the region and here in the room. I'm very excited to have Dr. Dan Reddy back to do what we're calling sort of a back to basics series. Shrish is going to talk about CMV. We are going to have several questions we'd like you to participate in today. So for everyone around the community and for folks here in the room, please pull out a mobile device or your phone. Please go ahead.
Okay, great. Yeah, Brian asked me to do this talk on CMV since we've talked in a couple of cases about serologies for CMV or PCR for CMV, and I thought it would be good to overview this topic. So just a brief overview of what I'm going to talk about, and mostly relevant to HIV itself. So in terms of viral basics, it's in the herpes virus family, so it's HHV5. We don't normally refer to it by the number like we do HHV8. We just call it CMV, and like other herpes viruses, it's a double-stranded DNA. It's ubiquitous, and most people, or a majority of people, have been exposed to CMV and may not have even known it. It's often asymptomatic or a mild flu-like illness or a mono-like illness in patients. And like other herpes viruses, it leads to lifelong persistence, so you don't clear the virus. In people with HIV disease, because of that reason where you don't clear the virus, most of the disease is from reactivation or even reinfection with another type of CMV. Like I said, the majority of people have been exposed, so around 60% of the US adult population is infected and would be serologically positive, but there are subpopulations that have a much higher prevalence. So greater than 90% of MSM are going to be seropositive for CMV, and that's important when we talk about who's at risk for disease and whether serologic testing is helpful in patients who have HIV who are MSM. It's transmitted by close person-to-person contact when we're talking about primary infection with someone shedding virus either through saliva or when we're talking congenital infection sexually. There have been, obviously, with transfusion and then solid organ transplant. And as we know, a disease occurs in people with HIV, typically with CD4 counts less than 50, so a very, very low CD4 counts. The incidence, fortunately, of CMV disease has dramatically declined with the advent of highly active antiretroviral therapy, and even more so in the current decade, we've seen very few cases of CMV disease overall compared to early in the HIV epidemic. So just to go through some of the clinical manifestations of CMV in patients with HIV, the most common one that I'll talk about is retinitis, but there's also GI disease and neurologic disease. But I wanted to make the point that CMVs can affect any organ, really, but we rarely see it cause pneumonitis in patients with HIV. That is something that we typically see more commonly in the bone marrow transplant population, but not in HIV itself. And although it can be seen from bronchoalveolar lavage in patients with HIV, it's usually there's another actual explanation for their pneumonitis or their pneumonia rather than CMV itself. And so I wanted to make that distinction in terms of CMV in the lung. So CMV retinitis is the most common one. We still see a spattering of cases here in Madison Clinic. I'm not sure if others continue to see CMV retinitis where you are. Symptoms, it can be asymptomatic, and we can actually see it as an unmasking iris. And so once people start antiretroviral therapy, I've had a patient who Brian cares for now over in the peninsula that didn't have any visual symptoms until he started antiretroviral therapy and then developed the classic floaters, blind spots, visual field cuts that you can see with CMV retinitis. This is a picture from HIV Web Study, a case of David's, that shows the normal retina and then what you can see with patients with CMV retinitis. And what you can see here, the yellow is really edema, and then the hemorrhages are the red spots along with that edema that's classic for CMV retinitis. Really what we want to make sure, though, is that these patients where you're suspicious about CMV retinitis, who have any visual symptoms and very low CD4 counts, that they get an immediate ophthalmologic evaluation by someone who's experienced, preferably. So we have a retinal specialist here who sees most of our CMV cases, and that's who we go to for when we're concerned about CMV retinitis. What they should ideally have is a dilated fundoscopic exam, so not just the kind that we do in the exam room, where I think people are getting less and less proficient at doing these because we just don't do them very often anymore, and we don't necessarily know what we're looking at, and that's I'm speaking for myself here. So I always rely on the ophthalmologist to help me out and do a really nice, detailed, dilated fundoscopic exam. And I wanted to make the point that you don't actually need to do laboratory studies or vitreal studies for the diagnosis of CMV retinitis. It's really a clinical diagnosis in the right clinical context, the characteristic findings on fundoscopic exam. So you don't necessarily need to put in that needle or have the ophthalmologist put in the needle to get vitreal studies to do PCR, that we end up treating basically based on these findings alone. So I wanted to throw in a question here just about CMV or the possibility of CMV in a patient. So what would you do? A 45-year-old man presents with diarrhea, 20-pound weight loss, and abdominal pain. He's diagnosed with HIV, has a CD4 count of 5 at that presentation along with all of these symptoms. You do an AFB blood culture, which is pending. You check a CMV PCR from the blood, which is 5,000 copies per mil, and a CT of the abdomen given his abdominal pain, which shows mildly thickened sigmoid colon. So what would you do at this point? So a wait for the AFB blood culture, as this is likely MAC in a patient with a very low CD4 count and gastrointestinal symptoms. Start antiretroviral therapy immediately, as he likely has HIV wasting along with his constellation of symptoms there, or start ganciclovir for CMV colitis based on his PCR that shows 5,000 copies per mil in the blood of CMV, or don't know, need more information. So I think while you're thinking about this, this is not an uncommon scenario. I think we've had a number of patients recently presented, complicated patients. I think Marie has a patient that she's been bringing up with lots of GI symptoms and wasting with a new diagnosis of HIV. So this is not an uncommon presentation. Okay, great. It's always good to ask for more information, I think, but a spattering of other answers here. So I wanted to go through this and specifically talk about CMV GI disease and then talk a little bit about how to approach this patient. So CMV in the blood, is it diagnostic of disease? And so that's the big question here. We see sometimes people will get CMV PCR and it's going to be positive, but what does that really indicate? I wanted to make the point that viremia can be present in patients, particularly with very low CD4 counts in the absence of disease. So the presence of viremia itself doesn't have a great positive predictive value for disease. Some would argue, though, that really high levels, so in the millions, would make you pause and say, okay, maybe that would be indicative of disease. But in general, in the OI guidelines, and when we're looking at diagnostics for CMV, CMV PCR by itself is not diagnostic, and neither is serology. One other important point to make, though, is that absence of viremia does not rule out disease. So in patients who had diagnosed by vitreal sample positive CMV retinitis, only 70% of those patients had viremia. So 30% had a negative CMV PCR in the blood. So again, it doesn't rule out active disease. And it doesn't rule in active disease either, the presence of it. So CMV colitis, so this patient actually has a fairly classic presentation for CMV colitis, but it's not really distinguishable from MAC, which can have very similar symptoms as well, or even HIV wasting. Weight loss, anorexia, abdominal pain, severe diarrhea, and malaise are the most common presentation. The CMV colitis can cause perforation and present as acute abdomen or hemorrhage, and those are obviously require immediate attention. Imaging can be normal or show colonic thickening, as it did in this person. Esophagitis is another presentation that's probably the second most common presentation of CMV in patients with HIV. The most common cause of esophagitis, I want to point out, though, is really candidal esophagitis, particularly in patients with very low CD4 counts. So that's usually our diagnosis, an empiric diagnosis, and what we do is treat for those patients with fluconazole, and if they don't get better, that should prompt further studying to look for whether they have another cause of esophagitis, namely HSV or CMV, to cause that. And the symptoms for CMV esophagitis are very similar to patients with candidal esophagitis, with odynophagia, nausea, and epigastric pain, which are classic. The diagnosis of GI disease, as I mentioned, it's not a serologic diagnosis or molecular diagnosis by PCR. It's really visualization of mucosal ulcerations on microscopy, whether that be with the EGD or colonoscope, and then in conjunction with histopathology, which shows these classic intranuclear intracytoplasmic inclusions that really tell you, okay, there's CMV in these cells that's causing inflammation and disease. So that's what it would look like on a colonoscope in the rectal mucosa, where you can see these ulcerations. And histopathologically on high field, you can see the cell, which is classic for a CMV infection. All right, so neurologic disease is a bit more grim with CMV. It can present with encephalitis, ventriculoencephalitis, and Guillain-Barré-like syndrome with a polyradiculum myelopathy. We actually have had a case of CMV ventriculoencephalitis not that long ago, a couple of years ago, that surprisingly she's still alive, which I think is very uncommon for these patients. It has a very poor prognosis. These patients with ventriculoencephalitis typically present with focal deficits and generally pretty rapidly, as opposed to a more subacute sort of dementia-like presentation. Again, the diagnosis is made clinically and radiographic findings in addition, in this case, to CSF, CMV PCR, which really can support the diagnosis. Patients, like I said, do pretty poorly with this and need very close follow-up. So, like I mentioned before, the distinguishing between replication, i.e. reactivation of disease just by CMV in the blood, versus true disease that's causing end organ damage is key. So we need to see evidence of organ involvement in HIV. Like I mentioned, it's in the eye, in the retinitis, or in the GI system mainly, or neurologically. Like I mentioned, it's not diagnostic to see, just to have the CMV PCR in the blood, and negative results do not rule out disease. Like I mentioned, when we're talking about IgG, it's really not that helpful. In our clinic, the majority of our patients are MSM, so they're going to have a positive IgG, and it's not really going to be very meaningful for them because it doesn't rule in disease or rule out disease. For the patients who have very low risk factors for having CMV disease, getting a negative CMV IgG may be helpful, given that it's normally a reactivation disease. However, we tend to not really screen our population and of our patients with CMV serologies. I'm not sure if other clinics do that standard. So in terms of what the OA guidelines recommend for screening of patients at entry for seropositivity, they actually say you may test patients at low risk, and it's a B3 level recommendation, so not a high level recommendation. And what they mean by low risk is that you're not MSM, not IDU, and you don't have extensive exposure to children in general, and particularly at daycare settings. So the first two really apply to our clinic population, as we don't have a lot of daycare providers in our clinic that are patients at our clinic. But given that the majority are MSM IDU or IDU, we don't really check. And that's consistent with the guidelines, which recommend no testing for all these other patients that are not considered to be low risk, given the seroprevalence is so high. So treatment, it's for CMV retinitis, it's a little bit different, so I'm just going to break it down by disease because it does vary. So with CMV retinitis, there have actually been multiple studies showing that oral valganciclovir induction is equivalent to IV ganciclovir induction for the majority of patients. And so 21 days of induction therapy, and then followed by a maintenance phase of therapy for at least 3 to 6 months, plus noting that the lesions in the eye are inactive, and that requires really regular ophthalmologic follow-up, and the CD4 count is greater than 100 for 3 to 6 months. So as you can imagine, most of these patients are on therapy for more than 3 months, and more than 6 months in most cases. Ganciclovir ocular implant was an option and was in the guidelines for a long time. It's still there in the guidelines, but it's not made anymore, so it's not actually an option in reality. So even though it's there, it's not an option. Intravitreal ganciclovir and foscarnet injected by the ophthalmologist in addition to systemic therapy is recommended for sight-threatening lesions. For other lesions, it's not as clear-cut of a recommendation whether that's given as adjunctive therapy to systemic therapy. For GI disease, as I mentioned before that there's a prolonged maintenance phase, that's the big distinguishing factor here. In GI disease, there's no maintenance phase recommended in the OI guidelines or secondary prophylaxis. Unless patients have recurrent or relapsing disease, then you can consider a secondary prophylaxis. But for the majority of patients, you don't need to do a maintenance phase, and it would just be the 21-day induction. Typically, ganciclovir IV initially, and once they're able to take PO and absorb properly, then they can do PO Valgan. For CMV CNS disease, ganciclovir plus Forscarnet to really optimize CNS penetration and eradication of the virus is recommended. The duration of therapy is really unclear, and it's based on clinical response. For our patient, who we work closely with, Dr. Mara, the patient received many, many months of therapy, probably close to a year of therapy with a combination or IV ganciclovir by itself. So she was treated for a very long time. Timing of ART, generally within 2 weeks, as is consistent with other OIs, except for CNS disease, may consider delaying. This is a really nebulous in the OI guidelines about optimal timing in CNS disease. I think it's really dependent on how the patient is doing and how much edema and how much neurologic dysfunction there is. But they do mention the sooner the better to try to improve their immunologic response to the virus. CMV prevention. Really not much we can talk about for primary prevention, given that most of our patients have already been exposed. But if you do manage to find patients that are seronegative, the recommendations are to recommend condom use, to avoid getting primary infection, hand washing, and CMV negative blood if they need a transfusion. No primary prophylaxis is recommended, and actually there's no secondary prophylaxis that is recommended except in the case of CMV retinitis, where you're talking about maintenance therapy. So just some key points. Seroprevalence is really high of CMV, particularly in MSM, so serologic testing not really useful. Almost all disease is reactivation in HIV. Most common clinical disease is retinitis in HIV, and important to distinguish disease from just replication without end organ disease in patients with HIV.